Good afternoon. My name is Brian Burke. I'm from the Vascular Testing section of the IAC, and my presentation is entitled Deviation from Diagnostic Algorithm. So what do we mean by this? Non-invasive diagnostic testing requires an interpretation to arrive at a diagnosis. Such interpretations are based on diagnostic criteria. The use of criteria like this is common in medicine. A couple of well-known examples I've given here. The Ranson criteria for pancreatitis assigns a point value to clinical and laboratory data to establish the likelihood that a patient has pancreatitis. The NACIT criteria for carotid stenosis for use with carotid angiography employs this methodology for calculating stenosis within the internal carotid artery and categorizes patients based on that into risk groups for which the determination for whether revascularization should be performed is made. Such well-accepted criteria are based on controlled multi-institutional trials with reference to pathologic or angiographic gold standards. The use of such objective criteria can improve the accuracy and reproducibility of testing. However, isolated criteria employed without regard for the clinical context can be misleading. In addition, in given cases, sometimes criteria lack internal consistency and can result in conflicting diagnoses or categories of disease. Let's look at a couple of examples within the realm of non-invasive vascular testing. This is a carotid duplex study, and if we look at this image here, we see that peak systolic velocity in the right internal carotid artery was measured at 169 centimeters per second. Using this as the sole criterion, we would arrive at a diagnosis of a moderate stenosis within this vessel. But let's look further at this case. As we see from the spectral waveforms here, this patient has an arrhythmia, and the systolic waveforms vary from peak to peak. The peak chosen here was relatively higher than many of the others, based on its distance from adjacent waveforms. If we look at other criteria that we use for deciding whether stenosis is present, there's nothing to substantiate this diagnosis. For example, the ICA to CCA ratio in this case is 169 over 148 within the normal range. The grayscale image shows no significant plaque burden or evidence of luminal narrowing. The color Doppler image shows no color aliasing to suggest the presence of a hemodynamic flow disturbance. So this is essentially a vessel which has no significant stenosis, but the use of our single systolic velocity criteria would have resulted in a false positive diagnosis of stenosis. Here's another case. This is a lower extremity arterial Doppler study in a patient who presented with calf claudication. If we look at the ankle brachial indices, both the right and left leg indices are normal in this case, which would result in a diagnosis of normal, no evidence of hemodynamically significant flow interruption in either lower extremity. But let's look further into this case. If we look at the segmental arterial pressures, at several levels, we see evidence of non-compressibility, likely due to the presence of heavy arterial calcification within the arteries, thus resulting in artifactual elevation of the ankle brachial indices. If we look at the pulse volume recordings, we see that this case is not normal. As we progress further distally in either lower extremity, there's progressive loss of amplitude and pulsatility of the waveforms. And at the digital level, there's essentially non-pulsatile waveforms present. So in this case, there is likely hemodynamically significant arterial disease below both knees. And the use of the ankle brachial index as our sole diagnostic criterion would have resulted in a false negative diagnosis. So hereby the dilemma for the interpreting physician. When the diagnostic algorithm based on established criteria results in a diagnosis incompatible with the clinical scenario, or if different criteria suggest mutually exclusive diagnoses or degree of severity of disease in the patient. This is a not infrequent problem in the setting of non-invasive vascular testing, which relies on velocity and pressure data to diagnose vascular luminal stenosis based on physics of hemodynamics as expressed in Poiseuille's law. These criteria are imperfect because the physical principles on which they're based do not apply perfectly in biological systems, and thus can result in deviations from the expected. So what are the potential diagnostic pitfalls that we can thereby encounter? So in carotid testing, there's the well-known case where compensatory increased flow can occur in a vessel contralateral to the site of hemodynamically significant carotid stenosis, resulting in elevated blood flow velocities in an otherwise normal vessel. A tandem stenosis is a situation where two separate areas of narrowing are present, spatially separated within the same vessel, such that the downstream stenosis occurs in the site of altered hemodynamics, which might affect our diagnostic criteria. Additionally, change in hemodynamic flow within the carotid artery may occur because of the presence of disease either proximal to or distal to the carotid artery, as for example when there is disease located at the level of the aortic valve, or if there is something such as an intracranial arteriovenous fistula. In the setting of lower extremity arterial Doppler testing, our example previous of arterial non-compressibility illustrated the problems with calculating ankle brachial index in these cases. Additionally, discrepancy in the calculation of ankle brachial index can occur when there is infrapopliteal disease, such that the use of either the dorsalis pedis artery pressure or the posterior tibial artery pressure might result in differing ABIs. Additionally, upper extremity vascular disease causing diminished brachial artery blood pressure may affect our calculation of ankle brachial index. For arterial duplex testing, the presence of multifocal disease in a lower extremity results in a situation analogous to the situation of tandem stenoses that we discussed for the carotid circulation. Additionally, when there is an occlusive lesion in the lower extremity, the presence or absence of collateralization of blood flow around the occlusion will result in a difference in the hemodynamic state. The situation with venous duplex testing is somewhat different, as the diagnostic criteria in this situation are generally not quantitative, but more qualitative in nature. Nevertheless, pitfalls can occur which affect the application of these criteria. For example, presence of developmental anatomic variants, such as a duplication of the femoral vein, might make the use of augmentation maneuvers to determine the presence of an occlusive venous lesion ambiguous. Additionally, the presence of chronic changes within a vessel subject to prior thrombosis might affect the use of criteria for establishing the presence of an acute DVT. So given this, how do we avoid pitfalls when deviating from the diagnostic algorithm? First, we need to accomplish internal validation of diagnostic criteria used in our laboratory. And we do that by correlating data acquired from our own testing with angiographic or surgical findings in these subset of patients. Also, do not rely on a single diagnostic criterion or cutoff value, but use all the data available to you from a given study. The velocity or pressure data, Doppler spectral waveforms or plethysmographic waveforms, grayscale and color Doppler information can all contribute to an overall picture that might supersede a single anomalous criterion. And also, if there are any special circumstances or clinical information in a given case, those should clearly be communicated between the vascular technologist performing the test and the physician interpreting it. In general, don't rely on tabulated data to churn out a result in cookbook fashion. Instead, put the data criterion in context with the entire test to generate a diagnosis that is compatible with the clinical presentation. In cases where the deviation from the diagnostic algorithm cannot be resolved in this way, consider the need for further or more invasive diagnostic testing. Thank you.